Good morning, ladies and gentlemen. Welcome to the Baker Institute at Rice University and the third biennial conference on healthcare reform. In your programs, you will, there are notes about our health program and our health policy program, and the recognition of our organizing partners and acknowledgments of people who and organizations that support this program. Such as the Sid Richardson Foundation, the Health Policy Forum. We'd also like to thank its members, the Baylor College of Medicine, the Madison Benefits Group, St. Luke's Episcopal Health System, Humana, the University of Texas, MD Anderson Cancer Center, and the Texas Children's Hospital, amongst others. The researchers in our health economics program view the high and rising costs of healthcare as the greatest barrier to high-quality care for Americans. By controlling healthcare costs, we can reduce insurance premiums and make healthcare and insurance coverage affordable for everyone. Our health economics program, led very ably by Dr. Vivian Ho, which I think most of you know, is collaborating with surgeons at the MD Anderson Cancer Center to identify factors that can lower costs and improve the quality of complex cancer surgery. We are working with Cigna Corporation to examine the effectiveness of a new medical home project in North Texas, which is aimed at reducing costs and improving care for diabetic patients. The Baker Institute is also collaborating with the UTMB and the MD Anderson Cancer Center to conduct comparative effectiveness research on cancer in Texas. And we are at the early stages of a project to evaluate a comprehensive worksite wellness program called Vitality, which has just been launched by Humana. Today, we will be analyzing our healthcare system from an even broader perspective. We are here to discuss the most significant legislation influencing the delivery of healthcare since the creation of Medicare and Medicaid in the 1960s. President Barack Obama signed into law the Patient Protection and Affordable Care Act on March 23, 2010. With over 2,000 pages of legislation, the Affordable Care Act, the ACA, touches every aspect of health insurance and health care delivery in the United States, both public and private. You most likely have heard about the ACA's personal mandate to purchase health insurance, the constitutionality of which is being challenged by several states across the country. But that's just the start. The ACA contains subsidies for low-income families to purchase health insurance exchanges for individuals and small businesses to purchase coverage, increased access to Medicaid, the creation of accountable care organizations among Medicare providers, and much, much more. In fact, so many program changes were included in the legislation that it was inevitable that some hastily prepared programs and regulations were suboptimal, inefficient, or perhaps even infeasible. That's why we titled today's conference Healthcare Reform: The Good, the Bad, and the Ugly. Some of you may have thought you were being invited to a rock concert, but that's the purpose of the title. Today, 5 of the nation's leading health economists will provide us with their views on healthcare reform. They will discuss the motivation for reform and the economic underpinnings of the ACA. In addition, 3 of our speakers will take a detailed look at specific aspects of healthcare that will be influenced by reform: the pharmaceutical sector, long-term care for the aging population, and the potential for industry consolidation resulting from the legislation. We have allowed ample time for questions and answers after each speaker's presentation. So please feel free to raise questions during this time regarding current developments in Washington or the Texas State Legislature or whatever else you wish to raise. We're looking forward to hearing from our speakers today and engaging them in a discussion which will better prepare us all in our efforts to achieve meaningful health care reform. The Affordable Care Act is a work in progress. and an informed public can be instrumental in influencing the implementation of the legislation. This is a key priority for our country. So thank you for attending this conference and for your willingness to participate in the public debate on one of the most important public policy issues in our country, the future of our healthcare system. Thank you very much.
Thank you, Ambassador Dirigian. Welcome. My name is Vivian Ho. I'm part of the Health Economics Program and the Health Policy Forum here at the Baker Institute. We're delighted that you could join us today. Let me just give you a couple of introductory remarks. First of all, thanks very much to our Health Policy Forum members who we acknowledge here. They don't just provide us financial support. They give us wonderful and very useful insights on health policy, and they're very supportive of our research agenda and our research goals, regardless of what we decide to study in our different projects each year. I'm the person that I got to invite the speakers today, and then send out invitations so that all of you could come. I'm delighted you could take the time out of your schedules to be here. But then all the rest of the work is actually done by a large group of people who help us here. I'd like to thank Joan Recht, who's the program coordinator for the Health Economics Program, and Mara Short, senior research analyst, and Melissa Llewellyn, who helps us. So we're going to get started with the speakers in just a minute. In terms of logistics, we do have restrooms. The ladies' rooms are on these side, men's rooms are on those side, and you've seen the refreshments, and we'll have box lunches out there at lunchtime. The speakers are going to speak for 40 minutes. And then after those 40 minutes, we've set aside 20 minutes after each speaker for you to ask questions. And just make sure that you use one of the microphones. There will be people who bring them to you because this is being webcast and people watching would like to hear what you are asking. So without any further delay, I'd like to introduce our first speaker, Amitabh Chandra, who's from the Kennedy School of Government at Harvard University. So Amitabh has the official bios are in the program, and you'll see we have speakers who have extensive accomplishments, and I'd just like to say something in addition to that. What you'll see from Amitabh's work is he's an expert on following cost and the diffusion of technology in healthcare, and that's what he'll be talking about today. But he's very wide-ranging. He's also done very interesting research that's been published in terms of practice variations and sort of the relationships between wages and healthcare. And he's also been commenting lately on editorials in the New England Journal of Medicine on Massachusetts healthcare reform. So he's quite wide-ranging. But with that, I'm going to just hand things over to Dr. Chandra and let things get started.
I'm delighted to be back at Rice University and at Houston. Houston is such an exciting city to study as a health economist because it in so many ways encapsulates all the good in American healthcare and all the bad and ugly in American healthcare as well. And so with that, let me just start to talk a little bit about technology and cost growth in American healthcare. So Houston, we may have a problem. This is a quote that comes from Peter Fisher, who was Undersecretary of the Treasury in the Bush administration, and he was testifying to Congress in November of 2002. And here's what he said. He said, "Think of the United States government as a gigantic insurance company with the sideline business in national defense. This particular company has made promises to its policyholders that have a current value $20 trillion in excess of the revenues that it expects to receive. It is an accident waiting to happen." So Peter Fisher has to be given credit for being one of the Cassandras of cost growth in American healthcare. In 2002, he was one of the people who sounded the alarm bells in Washington. What he is saying here in his testimony is that if you look at what the United States federal government, state and local government have to pay out by the year 2050 relative to the revenues that the federal government will take in, the federal government is expected to pay out $20 trillion more than what it'll take in the form of tax revenues. Two-thirds of that shortfall, two-thirds of that $20 trillion in 2002 comes from the growth of Medicare and Medicaid. This is before the expansion of Part D of the prescription drug benefit to elderly Americans. This is before the expansion of insurance to the uninsured, as Congress did last year. So if we were to update the Fisher analysis, as the Congressional Budget Office did last year, that number of $20 trillion now stands at $38 trillion. So we're now in 2011. By the year 2050, the United States government will owe $40 trillion in the form of Social Security, Medicare, and Medicaid benefits, more than what it'll take in. And this is the accident that I think is waiting to happen. So here's what we expect Medicare and Medicaid cost growth to look like over time. What you see from this exhibit is, first of all, a lot of the fiscal pressure is not coming from the Social Security program. Social Security will definitely grow as more Americans retire and make use of the Social Security program. But it's really cost growth in Medicare and Medicaid that will absorb a larger and larger share of the federal government's spending. By the year 2040, Medicare alone will take over the entire federal budget, which means that all the money that the government uses to bail out banks, to do infrastructure, to spend on education, national security, invading foreign countries, all of that will be Medicare spending in about 20 years. So what are we going to do about this? Well, one person who looked at these numbers was Doug Holtz-Eakin, who was the chief economic advisor to Senator McCain and Governor Palin. And when he looked at this graph at the time that he was director of the Congressional Budget Office, he said Social Security is Grenada, Medicare is Vietnam. And I think there's a lot of truth to his summary of these facts. Because what I think Doug Holtz-Eakin meant was, on Social Security reform, you can take a room full of very smart economists who are Democrats and Republicans, lock them up in a room, and tell them we won't let you out unless you agree on a consensus plan on how to rescue Social Security. I think that plan exists. I think we know how to rescue Social Security. On Medicare, we have absolutely no idea, and hence the analogy to Vietnam. One sense of the problems we're having in the Medicare program comes from this atlas. This is a map of geographic variation in spending in the Medicare program across 306 hospital referral regions. A hospital referral region, you should think of that as being a local market for healthcare. What you see in crimson, so these are parts of Texas, parts of New England where I'm from, parts of Florida, southern Los Angeles. These are areas of the United States that spend on average about $9,000 per Medicare beneficiary per year. Areas in yellow are areas of the United States where we spend about $4,000 or $4,500 per Medicare beneficiary per year. So there's a 50% difference in spending between yellow regions and crimson regions. This atlas tries as much as we can to adjust for the fact that prices are higher in Manhattan, so we don't want to be picking up the fact that Manhattan spends a lot on healthcare because it's an expensive place. We've tried to do the best job that we can to adjust for the severity of the patient population. But the question that I want us to focus on this morning is, what do we get in the regions that are in crimson versus the regions that are in yellow? This is a twofold spending difference that is a spending difference in a public insurance program. So this is Medicare. All Americans pay into Medicare, but we're taking out very different amounts from the Medicare program across these different regions. So what is the association between Medicare spending and the quality of care? Well, this is one exhibit. On the y-axis, so going from bottom to top, are the states ranked in order of the quality, diminishing order of the quality of care that they delivered Medicare beneficiary. So the states ranked number one are the states that did the best. On the x-axis, you have Medicare spending per Medicare beneficiary. And what I would have expected this line to look like was, I would have thought, well, we have problems with quality in the United States, so it may have been flat. I may have thought it slopes up, and then we could have had a conversation about how to make it slope up even more. But I don't think anyone expected this striking negative relationship with the amount of spending that we do and the quality of care received by Medicare beneficiaries. So Medicare beneficiaries in states like New Hampshire, Vermont, Maine, North Dakota, and Utah, these are states where we spend about $5,000 to $5,500 per beneficiary per year, and these are the states where quality does very well. In other states, in states like Texas and Louisiana and Mississippi, we spend a lot more, but the quality is very low. Now, some of that spending variation that you see on the x-axis could be a consequence of severity of patient illness and behaviors. There's no disputing that. But that is not enough of an explanation to explain why some states perform so much worse than others on these very simple quality metrics. So the question that you should be asking right now is, what and how did you measure the quality of care? These are very simple measures of the quality of care received by Medicare beneficiaries. So a typical measure of care is, did this Medicare beneficiary that we spent $8,000 on receive an annual flu shot? If Medicare beneficiaries are sicker in some states than other states, those beneficiaries in some sense need the flu shot even more. That's another reason for this line to be sloping upwards and not downwards. Other quality measures are things like, did diabetics who should receive an annual eye exam actually receive that annual eye exam? Or did a diabetic patient have their HbA1c evaluated? Or did a patient who came to the hospital for a heart attack receive beta blockers? Or did a stroke patient receive warfarin? So these are very low-tech quality measures that we seem to have a lot of trouble delivering in some areas versus others. It is not my argument today, and it'll not be my argument at all, that because we spend more, the quality of care is lower. That's not the argument at all. The argument is that despite spending more, we struggle a lot with delivering high-quality care, and that delivering high-quality care often doesn't require us to spend much more money. Another way to sort of drill deeper into the associations between spending and quality is to look at the scatterplot that I have before you in this exhibit. This comes from some work that John Skinner, Doug Steger, and I did for the Institute of Medicine 2 years ago. On the x-axis, what I have is spending for heart attack, hip fracture, and colorectal cancer patients. On the y-axis, I have 1 year survival for these patients. Each of those blue dots is a hospital in the United States that treated all three conditions. So there are 4,690 of these blue dots. And I would have thought that there would have been, again, a positive association between 1 year survival for patients who suffered one of these conditions and spending on those conditions. But for those of you who have never seen zero before, that red line is zero. So it's essentially saying that there's no association between spending more and getting better outcomes in some of these populations. What I want to draw your attention to is two clusters of hospitals. There's one cluster of hospitals over here that we worry a lot about. These are hospitals that on average spend something like $30,000 to $32,000 per patient on one of these conditions, but they were below the average in terms of 1 year survival. Hospitals in the upper left quadrant are hospitals that spent less than average but delivered better than average in terms of outcomes. So the policy challenge for all of us, Democrats, Republicans, Independents, is how do we take these hospitals over here and make them these hospitals over here? Is there something special about the hospitals over here that can actually be replicated down over here? I think there are people in Washington who claim to know the answer. My own sense is we don't actually know how to do that. But even though we don't know how to do that, I think graphs like this are incredibly tantalizing to policy analysts like me, because the promise of improving the delivery system is certainly an optimistic one. And I do think that someone in this room will, maybe it's someone here in Houston, will figure out how to take one of these lower performing hospitals and move them up over here. The differences in 1 year survival are really striking. Hospitals where the little green dot is, these are hospitals where 1 year survival was about 74%. Hospitals over here are hospitals that had 1 year survival of 64%. That's almost a 12-year difference in survival. So it's almost like hospitals over here are delivering medical care from 1999 at 2011 prices. That's another way to sort of scale some of these differences. These are extraordinary performance differences that we don't really understand. But again, the takeaway from this exhibit is because we spend more doesn't automatically mean that we get more as a result of spending more. And so finally, if I were to put it all together and just kind of give you a takeaway number, what would be the spending difference between, in Medicare, which is a public insurance program, for two Medicare beneficiaries who join Medicare at the age of 65 over time? And we're comparing outcomes in two cities, Los Angeles and Minneapolis. The difference is really a Ferrari Scaglietti. We could give each of those Medicare beneficiaries in Los Angeles a Ferrari Scaglietti. We know that they're not getting any better health care. I know that Ferrari would make them very, very happy. And so this is just an alternative way to reform the Medicare program is rather to give Medicare beneficiaries Medicare benefits, we could be driving Ferraris. Of course, this does raise the question of what do you get when you spend all that money on healthcare? It turns out you do get a lot, but a lot of the improvements that we've seen in survival don't often come from the high-tech therapies. And so here are some numbers that come from Earl Ford's paper in the New England Journal of Medicine. What Earl Ford's group did was to ask, what are the factors that explain the spectacular decline in coronary deaths between 1980 and 2000. So over this 20-year period, 1980 to 2000, why is it that coronary disease fell, or deaths from coronary disease fell as much as it did? And here's the taxonomy from the Ford papers. The first thing that I want to draw your attention to is that number of 61%. 61% of the mortality decline was driven by changing behaviors. It was driven by the decline in smoking, an improved control of hypertension, cholesterol, and a decrease in physical inactivity. We undid some of that with the 17% increase in body mass index in diabetes. So the behavior change certainly improved our performance from coronary disease deaths, but we undid some of that. So if you put these two numbers together, about 44% of the decline in coronary disease deaths may be attributed to changes in health risk factors. So health risks are behaviors. These are very different interventions than healthcare. Well, what about healthcare? If we look at the role of healthcare, it's about 47%. So half of the gain comes from risk factors, half of the gain comes from healthcare. But I want to draw your attention to the further breakdown of the spending on healthcare. It turns out that a lot of that decline in coronary disease that we attribute to healthcare, a lot of that, something like 35% of the 47%, comes from technologies like aspirin, heparin, warfarin, antihypertensives, beta blockers, and diuretics. These are extraordinarily cheap drugs. Even if we start to look at drugs like statins, ACE inhibitors, type 2 and type 3 antagonists, and thrombolytics for treating heart attacks, we're up to about, they're more expensive than aspirin, but they're a lot cheaper than the third category of healthcare spending, which is things like angioplasty, bypass surgery, cardiopulmonary resuscitation, and cardiac rehab. These technologies are life-saving. We have trial evidence that angioplasty, when done after a heart attack or done right after a heart attack, will save your life. Relative to doing the clot-busting drugs. So I'm not Mr. Anti-Technology. The point that I'm trying to make is that a lot of the gains that we see come from cheap things. And the expensive things do account for survival gains. There's no disputing that. Something like 12% of the gain comes from these high-tech medical interventions, but they account for almost all of the costs. If I could put these two things together, the things that improve health, this big circle over here, the things that improve health are the really cheap things. The things that drive up costs, but also improve health, are these really expensive things over here. So that would be one takeaway that I'd like you to remember at the end of this talk. So why are we having all these problems in American medicine? If I talk to my physician collaborators, the number one answer that comes up again and again is medical malpractice. There's absolutely no question that physicians are beleaguered by medical malpractice. If Vivian has me back, I'm happy to spend an hour talking about how we might reform medical malpractice. But the thing to remember about medical malpractice is, while we absolutely need to reform it in the United States today, it accounts for a very, very small share of the cost problems we're having. So I did some work on this with my collaborators at Harvard, Michelle Mello, Atul Gawande, and David Studdard. And here's a pie chart that summarizes what we found. If this pie chart represents medical spending in the United States, and we were to say how much of this is accounted for by medical malpractice, the liability system accounts for about 2.4% of all healthcare spending. 1.9% of that is defensive medicine. This is doctors doing tests and procedures to avoid being sued. And then there's also the costs from jury awards and settlements and administrative costs associated with these claims. This little slice is still a very big number. It's about $50 billion a year, which tells you something about the size of the yellow slice, which is $2.7 trillion a year. So I think reforming medical malpractice is a good thing to do. It's really important to get doctors on board, especially in an environment where we're asking so much of them. But as a panacea for solving the cost growth problem, I think it's unlikely to do anything more than give us $50 billion a year. And while that isn't small potatoes for a country that has absolutely no money, it's certainly not, something that's going to solve the problem of this pie growing 3 or 4 times the speed of GDP growth. So we need another explanation. An explanation that carries a lot of weight is that there is tremendous uncertainty about what works in medicine and what doesn't. And most doctors wake up in the morning and they try to do the right thing, but they often don't know what the right thing to do is. So 2 examples of this are Avastin, bevacizumab, a wonder drug made by Genentech for treating cancer. Bevacizumab for breast cancer costs about $90,000 a year. The most aggressive trials find a survival benefit of about 2.3 months. And we learned that years after we started using bevacizumab. So with something like bevacizumab, you have physicians, some of whom might be using it because it's a lucrative procedure to be offering patients, but many of them are just trying to do the right thing for their patients, and they don't have trial evidence on what the gains from bevacizumab to the breast cancer patient sitting right in front of them are. But bevacizumab really is a small problem relative to this other technology that I want to talk about. I want to talk about proton beam therapy for prostate cancer. Proton beam therapy for prostate cancer is like the Death Star of medical technologies. Nothing like this has ever been seen in medicine. The technology basically involves building a cyclotron the size of a football field at a cost of $120 million and creating a beam of photons so fine that when I have a little patient, there's a little patient sitting on a gantry. So this is the technology, and there's a little patient in red lying on a gantry. You put the patient on a gantry, and what the physician can do is zap only the cancerous cells in the man's prostate. We have absolutely no any idea whether proton beam therapy for prostate cancer works, and yet we do reimburse for it. So Medicare, the public insurance program that we have, pays $1,400 every time someone receives a treatment, and a typical man needs about 20 treatments. We have no idea whether this treatment works or doesn't. Just to put this number into perspective, $1,400 per treatment means that if I put a person on that gantry 3 times, that's the cost of insuring 1 insured person. So we in the United States have effectively decided that we would rather uninsure people than withhold an unproven medical technology from someone who is a Medicare beneficiary. And so this will raise a number of questions that I don't think I'll be able to answer at the end of the talk, but we might get some traction on hopefully in the discussion section. So that is proton beam therapy. Again, like I said, we don't really know if it works. We lead in its adoption. It's very, very expensive. It might be beneficial, but it would be difficult to argue that it generates this kind of benefit relative to a lot of the other things that we could be doing with this money. Second, in addition to uncertainty about what works, we reimburse doctors very badly. We give doctors very bad incentives to deliver high-quality care. And I think the biggest monster under the bed might be our reimbursement system, and in particular, fee-for-service reimbursement. So to highlight fee-for-service reimbursement, I want to draw your attention to this brochure I received. This is a brochure that I received from Siemens. I'm not a real doctor. I'm only an economist, but I write in medical journals, so I think the device manufacturers think I'm a doctor. So here's a brochure advertising a new technology called multi-slice computed tomography, MSCT. And here's a urologist staring off into the sunset, and this is the brochure that I received. So I opened this brochure, and I was really struck by this table in the brochure. This table tells me my return on investment were I to purchase the multi-slice CT. I could buy the multi-slice CT, and I have 3 scenarios. I could run it 1.8 times a day, 5 times a day, or 10 times a day. In each case, I'd run it 20 days a month. Why not? Medicare would reimburse me $220 every time I ran it. Now come over here to the very last column. If I run it 1.8 times a day, I would only break even over 5 years. This is the return on investment over 5 years. If I run it 5 times a day, I would make over 5 years about $850,000. Now if I run it 10 times a day, 20 days a month, get reimbursed $220 every time I do it, over 5 years I'd make $2.1 million. it would be very, very hard for me if I were a physician not to invest in this technology. So I'm not actually beating up on the physicians. I think that this is a consequence of terrible incentives that we have them practice under. Nowhere in this brochure is anything said about the value of this medical technology. The attention of the physician is drawn to return on investment over 5 years. So I think, fee-for-service certainly has this very, very dark underbelly. But I think the real problem with fee-for-service medicine is that it doesn't incentivize doctors to do the things that are responsible for improvements in survival. So this is a table that comes from Beth McGlynn's work in the New England Journal of Medicine that says that if you look at adherence to quality indicators across different domains of care, on average in the United States, Americans only receive about 54.9, 55% of recommended care. So these are using very rich quality metrics, regardless of whether one is looking at preventive care, care in acute setting, or care in a chronic setting. The amount of recommended care that patients receive is very low. It's under 60%. And again, under 60% would be fine if we were delivering sort of the Southwest Airlines model of healthcare, where we were charging on average $3,000 per person per year. But if we're charging $8,000 and $9,000 per person per year, it seems reasonable to ask, why aren't those numbers close to 100%? So that, I think, is the real problem with fee-for-service medicine, is that doctors are not incentivized to pay attention to these quality metrics, but they do pay a lot more attention to the multi-slice CT that Siemens invented. And finally, I think we struggle immensely with electoral politics. The electoral politics come in two forms. The first is the small group of providers, I say this again because I think the vast majority of doctors are incredibly professional, but there is a small group of providers that have absolutely no problems using patients' bodies as ATM machines hooked up to the United States Treasury. And they have a lot to lose from a reimbursement system that actually whacks this kind of behavior. But a lot of the electoral politics are us. We have a tendency to believe that we are entitled to infinite healthcare spending, even though we put in a lot less into this program than we're taking out. We're essentially engaging in some form of intergenerational looting, where I am voting infinite healthcare benefits to myself and then sending the bill down to your children or my children who are excluded from the electoral process because they're under the age of 18. And so that is a tension that I don't know how we will resolve in the years to come. There's a part of me that thinks that these really difficult questions about who do we cover and what technologies can we cover are not questions that Congress is really fit to decide on because of this challenge of electoral politics. And so an idea that I often flirt with is this idea that we need a new Fed for healthcare policy, not a Fed that actually micromanages decisions like, oh, we're going to cover proton beam therapy for this patient, and we will cover an angioplasty for that person. I think that would really destroy the practice of medicine. I'm thinking a much more high-level Fed that says, this is what we will spend on Medicare, and if you want vouchers, well, then here's a voucher, and you decide what you want to spend of that voucher that we've given you. So it doesn't really have to be a heavy-handed Fed, but I think that there's something to this idea that Congress has to be removed from healthcare policy. Because at present, there is this challenge we have, where this is from work that Kate Baker and I did. I just wanted to draw your attention to a trade-off that we've never made in the U.S. It never came up in this discussion around insuring the uninsured. We could insure 30 million people and give them essentially the health care that I just talked about, infinite health care. It would cost us about $180 billion a year. On the other hand, we could have insured 50 million people. So we could have insured 20 million additional people by giving them a less generous policy. And again, that's that trade-off about how generous do you want health insurance to be? Do you really want it to cover every frontline medical technology? And if the answer is yes, we should be prepared as a country to pay much higher taxes. The Congressional Budget Office estimates that at current Medicare growth rates, if Medicare is growing as fast as it's growing, the top marginal tax rates would have to increase from 35% to 92%. At 92% marginal tax rates, the United States is no longer the United States. We start to make Sweden look like a picnic. So for those of us who think medical technology is absolutely worth it and everybody should have access to everything all of the time, we should then be responsible and say, raise our taxes. And raise our taxes much higher than they are right now. I think the The reason I got interested in this, and this is my last slide, so this is where I want to end, is a trade-off that I think we've never grappled with in our country, which is 60% of all healthcare spending is done by the government. And in my state of Massachusetts, this is an ugly side of that healthcare spending. What I want to draw your attention to all the way over on the left is the increase in healthcare spending in Massachusetts from 2001 to 2011. Healthcare spending went up by 60%. Where did the money come from? We raided every other area of government spending for that. So we took a large part of that money out of education, out of public health, out of mental health, out of infrastructure, out of human services, out of local aid, and out of the police force. That is the way that we're spending for healthcare, at least in Massachusetts. I haven't done this analysis for other states, but an unwillingness to raise taxes, but a willingness to offer everything all of the time results in this sort of uncomfortable arithmetic. And for that reason, I think we need perhaps another mechanism to decide how much we want to spend on healthcare. And so here's a slide that you've already seen. This is the waiting for Superman moment. I really don't have the answers, but I hope that there's some really thoughtful Rice student out there in the audience who can figure all of this out. Thank you very much. Did you want me to take questions?
Hi, thank you for your presentation.
You're going to solve it, right?
Maybe in my lifetime. I've been thinking that in other industries, technology has lowered the cost of doing business by standardizing and automating business. For example, conveyor belts. In medicine, it seems like it's the opposite. It's more personalized and it increases cost. But there is a lot of work being done to write evidence-based guidelines and even analysis of different tests and making matrices to see which tests are most useful and most predictive. But as a public, and I think within the medical industry, there is a very visceral reaction to what we call cookbook medicine. Do you see promise in this type of technology, which is very different from the technology that you've been talking about?
The information technology, where information is literally this works, this doesn't work.
Yeah.
Look, I'm not I think medicine is an art, and I don't think we can take medicine. What we've done right now is we've taken medicine and discretized it into 15,000 billing codes. That's what we've done with fee-for-service medicine. And if we ran 15,000 trials, we would have reduced it to 15,000 little pieces of information. I think it's substantially more sophisticated than that. I do think we can give doctors help on the things that work and the things that don't work. And I think that what we could do is design smarter insurance that takes that evidence from the clinical trial and turns it around to the patient and says, you know what, proton beam therapy for prostate cancer, we have no trials on this thing and it's fabulously expensive. If you want it, you can have it, but the coinsurance for it is 80%. I think that kind of tying information to the generosity of the insurance plan is probably the best use of the information. In addition to telling doctors, there's a number of therapies that have been shown to fail in every medical setting. Most doctors, I think, when given that information, most of them, again, are willing to do less of those technologies. But I'm very uncomfortable with this idea of being incredibly prescriptive about what physicians should be doing, because the heterogeneity in patient preferences and patient benefit is enormous. And so while we learn a lot from trials, the best way to use trials is to tie patient cost sharing to the result of the trial. And if there's no trial, it just means we don't know, and so maybe you pay a lot because we don't know.
Dr. Chandra, when you had the map up with the crimson areas on it, the first thing that came to my mind was a 2009 story that 60 Minutes did on the pilfering of Medicare by basically criminals. And they said that there was about $60 billion that was taken out of the Medicare system because of this kind of fraudulent activity. I was wondering whether you had adjusted your numbers to account for that. And
go ahead.
Well, I've got another part to the question or comment. But
two questions.
And the other question, well, it's more of a comment that I think needs a policy answer. Right across the courtyard, we have the Jones School of Business that has a business competition every year. And more than a third of the plans that get submitted are healthcare related. And it's interesting to watch as these new businesses design their treatments to be as expensive as they can possibly be, meaning that when they could have reusable pieces, they don't. They make them disposable so they can charge more money. And without some kind of policy to address those kinds of issues, healthcare's just in a bad spiral.
I think your second point is the point that I was trying to make about fee-for-service reimbursement. We have a reimbursement system where providers are incentivized to do more, to bill for the more lucrative procedure. And so we have to end that in the long term. And it would also free up doctors, because right now many of them are like hamsters on a treadmill. You know, they're seeing patients, they're just sort of churning patients every 15 minutes because they have to hit these RVU targets. It would be, I think doctors would prefer to see fewer patients, but each patient for more time and actually deliver some of that high quality medicine that we're struggling with delivering. But all of that requires getting rid of fee-for-service medicine. I didn't talk this morning about fraud. I spent a lot more time talking, if you will, about waste than fraud. Waste is sort of the overuse of things relative to what it costs to provide those things. Fraud is fraud. Fraud is what happens when doctors use the Social Security numbers of dead Medicare beneficiaries to bill for treatments, when Medicare carriers bill for procedures using the Social Security numbers of dead doctors. That's fraud. And I think there is evidence that in certain areas of the United States, Miami seems to be particularly entrepreneurial in this sense. The Russian mafia, according to my colleague Malcolm Sparrow, the Russian mafia left the business of selling drugs in Miami and joined the home health fraud business because that's how lucrative it became. The best numbers I've heard, the most aggressive numbers are $50 to $60 billion a year. So again, we should do more on fraud. Medicare, the government program, does very little on fraud. The private insurers do a lot more on fraud. But we have a tendency to call that administrative spending, when in reality that's actually valuable. So I think we should be doing more on fraud. And the great thing about fighting fraud is there's no pro-fraud party in the United States. This is one thing that they should both agree on doing more on. I guess the larger point, though, is fraud is not a source of cost growth in the U.S. I think it'll probably give us about $50 billion a year. Every year, which is a lot of money. But if we look at why spending is increasing so much faster than GDP, it's because of the diffusion of these new medical technologies that we reimburse for without asking, was it really worth it? Yes, ma'am.
I have a question about how I'm interested to know what are your thoughts on the way healthcare research is funded in our society. Because your earlier comments speak to the fact that
the best quality research is done to prove that a therapy is beneficial, and then doctors could be better educated to engulf those techniques. But the lion's share of research is done by the pharmaceutical industry, who sets the trials up specifically so that their drug wins. And the question that the pharmaceutical industry has is not the same that a physician like me might have if I design the trial.
Yeah.
So I've walked on both sides of the line where I did clinical trial design at the Brigham, and now I'm deep in practice, and I'm quite troubled by how we set the quality measurements based on research that's guided and funded by sources that we can't control.
Absolutely. I think we will have to make a much bigger commitment to spending on knowledge, because this knowledge isn't free. And as you know, these trials that pharma does are exorbitant for pharma, and pharma is doing them in patients that are most appropriate for the particular drug or device that was manufactured. To do trials in all these other populations will take a lot of money. Even if we triple the NIH budget, we may not be there all the way. But I think one quick response I have to you is, we don't necessarily have to spend more. We could change the default spending decision. Our default spending decision is, we will cover it even though it's unproven. If we change the default to, we will cover it if it's proven, and if it's unproven, we will charge you more, that alone could get us 30 to 60% of the way.
Is it work? Yes, it is. Thank you, Doctor Chandra. You began your speech with a discussion of Peter Fisher's numbers, where the United States became a giant insurance company, and it's now 38 trillion in the hole that it can't get enough to cover. And we talked about 60 million in fraud on an annual basis, and of course that's a tiny drop in the bucket. And I'm glad to see that the crooks can't keep up with the doctors in running up the cost. I was absolutely stunned by your brilliant suggestion at the end that encompassed the whole giant picture and said, take Congress out of the healthcare business, because taking Congress out of the healthcare business removes the political pressure to keep coming up with the 38 trillion in deficit that can never be made up. It keeps Congress from spending from future generations, and it puts vouchers into the hands of individuals and returns the doctor-patient relationship to what it was at one time before it became national, before it became federalized. And there is another way to do that, and it's equally radical, absolutely unheard of. And that's to remove the insurance industry from healthcare. You have a built-in 25 to 40% margin of increased costs anytime a third party steps in between the doctor and the patient. And that third party has a license to gamble on risk. It can get a license from the state, and it can charge premiums only after it's consulted with actuaries to be certain that there will be a profit at the end of the day. Those insurance companies they were the only ones behind the Affordable Care Act. They wanted more people into the pool. They wanted more people into the pool because somebody somewhere would have to pay the premiums. It didn't matter to them who. Now, it's radical to take Congress out. It's radical to take insurance out. But eventually, at the end of the day, one of the two has to go. Thank you.
Well, maybe both can go. I think if you asked economists how would you design health insurance, it's a lot easier if the insurer, Marty will probably set me straight on saying what I'm about to say, but my sense has always been that the ideal delivery system would be one where the insurer and provider were vertically integrated. So this would be a world where you have a hospital and an associated physician staff that are responsible for my care, and that I, as a patient, decide where I want to spend my healthcare dollars, and I give that money that I have to that particular provider group that's also my insurer. So in the chance that I'll end up being a lot more expensive, that group then bears the risk. We'll still need someone to be the insurer. So we could get rid of the insurers today, but the insurance industry is not going away, because healthcare is all about this long tail of very risky events where someone wants to pay a $4,000 premium per year, but there is a 1 in 100 chance that they'll end up being the $600,000 chemotherapy patient, and so they'll need a lot of health care in that world. So we'll still need insurers. They just may not be the insurers that we have today. They may be insurers, that result from hospitals and doctor groups getting together. Yes, sir.
You were talking about incentivizing doctors to help keep costs down. Of course, that's tough because that's going to could very well reduce their incomes.
Yeah.
I was wondering if we worked it also from the consumer end of it or the patient end of it to incentivize them to understand the effectiveness of the treatment, know that it would be covered, but could deny the treatment if there's any incentive there, because today there's no incentive. It's either use it or lose it.
I agree.
I'm wondering if you've
I agree.
thought
I think
of
we
that.
could engage patients a lot more than we do. And in some sense, I've always been puzzled by a lack of innovation by the insurance industry. The insurance industry could, in theory, say to patients who are about to have, say, an orthopedic procedure done to them, the insurance industry could say to a patient, hey, Amitabh, I will waive your coinsurance or your deductible for this procedure if you watch this shared decision-making video. I'm not telling you you can't have the procedure. Just watch the video on the potential side effects. And then I think we would have a more informed consumer. And so that's something we could do right now. That doesn't take federal intervention or state intervention. I'm always puzzled as to why we don't see more patient engagement by insurers. The doctors, it's not really, under fee-for-service medicine, they have no incentives to sort of engage the patient. We're asking too much of them. It's really the insurer's job to engage the patient. And I'm puzzled as to why they haven't innovated. But going forward, I could see a lot of insurance offerings where you do engage the patient, and we say things like, look, if you want things that are unproven, you pay a higher premium. But even conditional on a particular policy, we want you to have these conversations with your provider on side effects and how you value all these different side effects as a way to at least reduce the utilization of some of the procedures in some of the stents and some of the orthopedic procedures.
Thanks for coming today. I'm actually from the Jones Business School. We were mentioned a few minutes earlier. One of my questions is, coming from an engineering background and looking at healthcare, is that you have technologies out there that can reduce health costs. And I was wondering, from your perspective, what are some other barriers along with the fee-for-service that prevent these technologies from getting into hospitals and helping reduce those healthcare costs?
Well, this connects to the very first question. Here's the puzzle with technology in healthcare. The way it often reduces costs on a per unit basis. So angioplasty may be superior than bypass in a number of settings. It's a lot cheaper. The new robotic devices that Da Vinci has been inventing dramatically increase physician productivity. And so on a per unit basis, they save costs. But the downside of these medical technologies is that they can then be offered to everybody. So even though price per patient falls, you can actually now do this on many more patients. And so we're going to always struggle with these technologies. They're not particularly invasive. The less invasive a medical technology, the more it lowers costs. But the less invasive a medical technology, the more likely it is that I can offer it to other patients because it's not that invasive. It's not going to do that much harm. And so I think the challenge is we would love to keep developing these technologies and embracing them, but incentivizing doctors not to sort of overuse these technologies in other patients. So that's a reason why the answer to that lies in reimbursement policy, not innovation policy. I think the innovation we have is terrific. What we have to do is figure out a way to make sure that even though angioplasty is cheaper than bypass, that doctors aren't doing angioplasty to every 35-year-old man who walks into the ER complaining of chest pain. Right, but we could do angioplasty to those people. That's an overuse of angioplasty, but we welcome angioplasty. So I think fixing this overuse is a reimbursement system problem. And maybe the answer lies in paying doctors more. We don't have to, we could always say to doctors, hey, we will pay you more to do less. Just keep people healthy. And I think, doctors would like that.
Thank you very much. I think one thing you failed to mention about Houston is that for many of us, when maybe the healthcare industry tanks, so we at least have oil and gas as a backup here, at least for the IT guys, we can go there. I thought one thing that was very interesting and probably one of the most eye-opening statistics for me was the focus on the decreased morbidity just based on patient behaviors and habits. And so I know a lot of the focus is on, reimbursement and things of that nature, but it seems like, we should hold, consumers more culpable for their own behaviors. And I'm wondering if you, kind of predict down the road in the future, insurance companies are going to start, holding patients, maybe denying them or charging them more if they're smoking or if they're, obese. And, I know it may sound a little bit cold, but that's really the reality of, I think, part of this plan to, decrease our costs and improve outcomes down the road.
I have nothing to say on that. I'm not an expert on sort of where the insurance industry is going. My strong sense is that with a lot of the regulations we just passed, it's going to be harder for insurers to price discriminate on the basis of patient behavior. And that's a funny thing, because on the one hand, a lot of us have this sense of social justice, that if a patient has a genetic disorder, they shouldn't have to pay a higher premium than this other patient who didn't get sort of a bad draw in the genetic lottery. But at the same time, that sense of social justice also has this side effect that I am not going to charge the patient who, goes to Denny's every day and eats at the IHOP for lunch, a higher premium than the patient who doesn't, or the patient who chooses to work out. So I think that's the underside of sort of, making sure that insurers are charging sick and healthy people the same premium. I'm looking at this to the table of experts, that someone can speak to this more than I can, because that is not a trajectory that I've really been studying. And my limited understanding of the Affordable Care Act is it'll make it harder for insurers to price discriminate on the basis of patient behavior. Yes, ma'am. And then you, Mark.
What a gentleman. Thank you very much. I'm really fascinated, and I appreciate the, first of all, intergenerational looting comment, and I also appreciate the addition of politics into the discussion. My health law practice includes government relations, which is an academically acceptable way of saying lobbying. So I do that quite a bit, and I try to explain to the legislators, both at the federal, state, and local level, how important some of these decisions are and how we can make it palatable. But we all know, with the Republican primary happening right now for president, and even more local and state elections, intergenerational looting is very difficult to talk about. It's very volatile. It's very controversial. The word Ponzi scheme we've learned we can't use, and some other things like that. So I'm interested in hearing what your thoughts are based on the political lay of the land, because it's wonderful that we have such experts and we've all written articles and published on the subject, but the idea of not having Congress involved, for example, I'm not sure if that would be something we could even legally do as a nation, but there seems to be a real need for a solution to have policy work with the politics of the lay of our land and equalize the spending between the elder generation and the child generation and in between. Thank you.
So I take a lot of strength from the fact that after the stock market crash in 1929, when we sort of messed up monetary policy, we created the Federal Reserve, and we took Congress out of the business of monetary policy because we figured Congress couldn't be trusted with monetary policy. And that institution, people criticize it, is generally viewed as being a successful institution. And perhaps it's possible that today's Congress will I think most congressmen feel terrible when they're confronted with the fact that we're spending on healthcare when we should actually be spending on education, because spending on education is not only good for wages and productivity, it might actually be a better way to increase people's health than spending on healthcare itself. I think most congressmen acknowledge that, but then they're confronted with the reality of who shows up in the voting booth, and kids can't vote. So, I'm very optimistic that we will wrestle with this and, never let a good, I don't know who said this, but never let a good crisis go to waste. And so maybe what will come of this is exactly a conversation around taking Congress out of it. And Congress may be willing to do that delegation. Mark?
So one thing that I just want to raise as another possible sort of contributor to getting this trajectory on a better in a better direction is we've talked a lot about incentives for healthcare providers, but also we could think about dialing or varying financial incentives for Medicare recipients. So right now, basically, if a person gets admitted to the hospital, they're through the deductible immediately if they spend a night in the hospital. So there's no incentive, financial incentive, to think about, do I want the really intensive treatment while I'm here or not? Similarly, on the sort of outpatient stuff, most Medicare recipients have Medigap plans, so they're totally insulated from the financial consequences of their decisions. And so I wonder, I don't know, would it make sense going forward to think about changing that in a way where you sort of recognize that some people have very limited means, so you don't want to expose them to a lot of financial risk, but maybe have more financial incentives on the consumer side? You could have out-of-pocket maximums that increased with people's lifetime income. So if you earned $300,000 a year throughout your life, you shouldn't have a deductible that's the same as someone who earned $15,000 during their life, perhaps. And that would be a way to potentially cause people to get more efficient care and to mechanically lower Medicare spending. I don't know what you think about the possibility of those kinds of things.
I've been a long advocate of increased patient cost sharing. I mean, I think that in every other sector of the economy, we engage patients, and through competition, we drive down prices. This is no different. My only pushback is, I think we could raise patient cost sharing. We should eliminate Medigap. Two pushbacks. One is, it's not enough. I mean, the biggest price elasticities of demand we have are 10% increase in cost sharing would reduce spending by 2 to 3%. We have to do a lot more than 2 to 3% for some of these things. But, it's low-hanging fruit, and so we should absolutely do it. There's a flip side of this issue, which is trying to connect some of the questions that I heard earlier this morning. It may also not be the case that all we want to do is increase patient cost sharing. For some of the drugs that really keep you out of the hospital, we should have negative cost sharing. I don't know why we have cost sharing for diabetes drugs. It's not like diabetics are like trying to overuse their diabetes drugs. And so those patients should be paid maybe to take their drug because it avoids the downstream dialysis, the downstream leg amputation. And again, it's an example of an insurance product that has really not been developed. And so I've often, again, I don't understand why it hasn't been developed. But maybe, whenever we get Superman or Superwoman in the room, I think one of the policy levers that they should consider is smarter cost sharing. Certainly higher cost sharing for these gray area medical procedures, and lower cost sharing and negative cost sharing for the things that really save people's lives.
Well, thanks very much.
Thank you, Vivian. Thank you.